We have another award which goes to early career investigators. This Young Investigator Award is for Kimberly Lamberti from MIT. She's going to present about pulmonary vascular dynamics determines right heart tolerance of LV mechanical support. Congratulations. We have a picture, George.
Thank you so much. It's really an honor to receive this award and to have the opportunity to discuss my work with you all today. I am currently a PhD candidate, and I'm working in Professor Elazar Edelman's lab to study the mechanisms of right heart tolerance to left-sided support. So starting off broadly, there's this tension in the field that's motivating so many of us here, which is that cardiogenic shock incidence rates are rising. Coupled with that, there have been incredible advancements in the technologies used to treat shock patients. However, mortality rates remain high. And so that leaves us wondering, is cardiogenic shock simply immutable in some patients, or do we perhaps need to expand our focus in how we use these technologies and treat these patients? So one of the critical challenges to study is the onset of RV failure following LV assist, particularly in the dynamic domain of cardiogenic shock. To demonstrate what this looks like clinically, I've pulled 3 different cases of patients who received left-sided support with the Impella CP, and then after a period of time, they received right-sided support, indicating emergence of RV failure. In this first patient, you can see that after the CP was placed, pressure stabilized, the patient seemed to be doing well, and then after an hour, the patient suddenly coded, and they found through echo that the LV was completely collapsed, presumably due to RV dilation and failure that then impinged on the LV. In the second patient, after the CP was placed, the team found that they couldn't increase the speed without experiencing suction events, and again, through echo, found that this was due to severe RV dysfunction, showing how the right ventricle can truly limit the utility of left-sided devices. And then lastly, in the third patient, after the CP was placed, the physician wanted to sit and wait for 20 minutes to make sure the right ventricle wasn't failing. So this was a risk that they were fully aware of, and they feared this outcome. However, there were limited metrics to predict its occurrence. Expanding broadly then, what can happen after initiation of left-sided support is either this unmasks existing RV dysfunction or can induce added stress on the right ventricle. And in either of these cases, the right ventricle is now unable to keep pace with the mechanically enhanced left-sided output, and this imbalance in flows leads to a progressive cycle of decompensation in both ventricles and limited utility of left-sided support devices. This is a prevalent outcome, and it's associated with higher in-hospital mortality, but remains this critical challenge due to limited understanding of the mechanisms that create this outcome, and as a result, few metrics that can predict decompensation prior to the point of failure emerging. So considering the mechanisms then, it's important to understand the differences between the right and left hearts. So the right ventricle compared to the left ventricle is highly compliant and afterload sensitive, and the pulmonary circulation compared to the systemic is surrounded by the lungs and has this unique function to maintain the fragile alveoli capillary barrier. Despite their differences, though, the ventricles are highly coupled, both in series through the closed-loop circulatory system, as well as in parallel with intracardiac force transmission, allowing for systolic and diastolic interdependence between the ventricles. And it's this coupling that allows for not just vast changes in left ventricular load with mechanical support, but also significant changes in the right heart. So this foundation then leads to our hypothesis, which is that increased appreciation of those right heart mechanics and RV-LV coupling can improve outcomes of left-sided support through guidance of titration of support based on biventricular function, and by predicting the need for RV intervention earlier, which has been shown to improve patient outcomes. To assess this hypothesis, we designed a porcine model of varied right and left ventricular loading states to allow for mechanistic analysis of tolerance and intolerance to mechanical support. This consisted of 5 animals with 5 loading states each, and those loads included the healthy, intact heart, and then 4 gradations of acute cardiogenic shock, which was modeled through 2 rounds of coronary microembolization to induce LV ischemia, followed by 2 rounds of pulmonary microembolization to induce added stress on the right ventricle. You can see we had vascular access throughout the cardiovascular system to obtain continuous right and left ventricular pressures and volumes, as well as arterial pressures to understand the holistic cardiovascular response. And we studied then the response to PVAD unloading with the Impella CP across P-level ramps at each of those 5 loading states. So diving into the results then, one of the critical components of our hypothesis was in understanding the differences between the systemic and pulmonary vasculature. So looking at the systemic first, we see that flow, or cardiac output, is dominated by changes in the pressure gradient across the vascular bed. So as the analogy goes, the systemic circulation essentially functions as an ohmic resistor. In comparison, though, the pulmonary circulation has an entirely inverse relationship, and this is because the pulmonary circulation actually acts as a Starling resistor. So there can be vessel recruitment and distension that allows for broad changes in pulmonary vascular compliance and resistance according to cardiovascular state. And then what that means is, as you can see in the lower right panel, that the pulmonary circulation is dominated by the RC time constant as a finely tuned RC circuit. So in contrast to the systemic circulation, the pressure gradient is maintained in the pulmonary circulation until there are limitations reached in those Starling resistor capabilities. Translating these findings then to the response to PVAD unloading, we found that it's this unique aspect of the pulmonary vasculature, principally the compliance-mediated impedance, that dictates right heart tolerance to support. So you can see this shows the spectrum of states modeled across P-level ramp studies with the device. And on the right-hand side, with high pulmonary vascular compliance, we see adaptability and tolerance to PVAD unloading, and the transpulmonary pressure gradient is maintained. But with progressive volume loading and disease in the pulmonary vasculature, that decreases pulmonary vascular compliance, and we see limitation and intolerance to support, so that with the P-level ramp, the transpulmonary pressure gradient now increases. So that describes those series interactions between the ventricles, and we found that this also dictates the intracardiac response. So on the left, as the pulmonary time constant increased along this spectrum of states, which was associated with intolerance, we see that the preload ratio between the ventricles also increases, indicating added stress on the right ventricle. And furthermore, then, that preload ratio at the start of a P-level ramp then dictates the degree of unloading achieved by the device. So as the preload ratio increased, indicating that diseased and intolerant state, we had reduced decrement in LVDP, so reduced benefit from the device. And then lastly, we linked these findings to the actual ventricular functional response. So you can see as P level increases, the change in RV function corresponded with the change in LV function for both contractility and relaxation metrics, which first indicates the profound interdependence between the ventricles. And then furthermore, if you look at the color range in the cases of high pulmonary time constant indicating intolerance, this was associated with greater contraction and relaxation rates in both ventricles, which indicated a response counter to what you would expect from unloading or hope to achieve. So in conclusion, we know that maximizing device use and patient outcomes requires better prediction of right heart tolerance. And through these mechanistic studies, we revealed that it's the pulmonary vascular function that allows for right heart adaptability in response to stress. However, in cases of volume load and disease, this can limit that adaptability, which leads to right heart intolerance and diminished benefit from PVAD support. So moving forward, we hope that bedside metrics based on pulmonary vascular function will improve tracking of patient tolerance to support. Then I'd just like to acknowledge the vast support that I had in conducting this work in my lab and through collaborators and funding, and a special thank you to my advisor, Professor Edelman, and a close collaborator and mentor from Johns Hopkins, Dr. Steve Keller. Thank you all.